Hi, Mike Gibson, Tony DeMaria coming to you live from San Diego here at SCAI 2018. Easy trip for you, coming right from home over to the meeting?
Yeah, well, they said there was no honorarium, but I could travel first class.
So talk to us about the Hildner Lecture. What did you talk about today?
So I had a couple of messages. I entitled it Interventional Cardiology at a Pivot Point. And the gist of that was that interventional cardiology to this point in time has been 90–95% coronary and vascular, but structural is emerging very rapidly. Now, from the vascular standpoint, although the role of interventional cardiology in acute coronary syndromes is clear, it's not so clear in chronic stable angina. If you look at Courage and you look at Orbiter and some earlier trials, it's not clear which patients in the chronic stable angina category will benefit from intervention. And so I think that population is going to shrink for a while people do coronary physiology, hardcore physiology, to determine in which patients the obstructive lesion causes the ischemia and in which patients the ischemia is due to something else like microvascular dysfunction. But at the same time as that's constricting, I see an explosion in structural interventions. The aortic valve is here, mitral will come, tricuspid is being investigated. You have all the congenital lesions that are susceptible to catheter intervention. And there's even things like balloon pulmonary artery dilation for chronic thromboembolic disease, and even renal artery denervation is making a bit of a comeback. So I guess what I would say is that interventional cardiology will always have a firm basis in coronary and vascular interventions. But if I was betting, I would bet that maybe as much as 50% of cath lab volume will be structural in the next 5 years.
Tony, so many people say, boy, it's really tough in medicine today. You've had a long career. Is it tougher today, or has it always been a struggle?
So I think that today the struggle probably relates most to the economic factors. We used to have a lot more independence. It was a more lucrative profession, and that's changing now. I think the last data I saw, 75% of cardiologists are now employed.
Right. Used to be almost the inverse, right?
Absolutely the inverse. And with that employment comes restrictions on what you can do and how you can do it, and that's changed things a fair amount. On the other hand, it's such an exciting time to be a cardiologist. Just go around the SCAI meeting and look at all the innovation that's coming: structural heart disease and coronary artery disease, artificial intelligence, cell therapy. It's really an exciting time, and I can't think of anything I'd rather do than be a doctor. I mean, I couldn't see myself selling life insurance.
No, sure.
So when people ask me, you know, would you advise your kids to go into medicine? I said, absolutely. Absolutely.
What were some of the high points throughout all these years?
So I think way back when I first started, the explosion in imaging. You know, when I was junior faculty, echocardiography was coming in, and nuclear medicine, and all of a sudden we had a lot more data to go by than we ever had before. The vasodilator concept of the treatment of heart failure was a big deal. When I was an intern, people thought if you gave a vasodilator, you'd kill the patient. If you gave a beta blocker, you'd kill the patient. So that was a big thing. And then Andreas Grunzig came along with intervention, and that was an extraordinary change, that you could treat people with a catheter instead of doing bypass. And one thing, Mike, that's always impressed me, none of these things received funding from the funding agency.
Yes. Nobody
gave Rene Favalaro a nickel for developing bypass surgery, or Harvey Feigenbaum for echo, or Andreas Grunzig for intervention, for all the millions and millions and millions of dollars that are spent on research. Most of the big clinical advances really were unfunded.
But always, one of my favorite quotes is, "Stop telling me it's impossible while I'm doing it." You know? So that's very true. You know, I was on the way out reading a Harvard Business Review article on leadership. Leaders are always defined by certain kind of pivotal moments that were challenges that they overcame, and that kind of molds them and shapes them. What were some of those critical moments for you in your journey as a leader?
So I'm not sure I'm qualified as a leader, but I would say pivotal points in my life when I was coming out of the service, selecting a fellowship. I was fortunate enough to be offered positions at Yale, at Duke, at Emory. And I chose to go to a very small program that was starting in Davis, California. Most people couldn't even identify Davis, California on the map. And that was the most important thing that ever happened in my life. Because it was small, I had direct access to Dean Mason and the rest of the faculty. And if I came up with an idea, that weren't 2 or 3 people stacked up ahead of me that you had to go through. And it was an extraordinary opportunity, just an extraordinary opportunity to grow academically. And then as a bonus, when Dean Mason became president of the American College of Cardiology, that opened some doors for me to be active. And so if I look back on my career and whatever I've been able to accomplish, I trace it all back to that decision not to go to a big, prestigious, established program, and not to demand that I have somebody hold my hand to teach me how to do everything. I think that was a seminal event in my life that helped me every step of the way.
Who are some of the biggest mentors in your career? Who really had an impact on your career?
So, Dean Mason, for sure. He went to Davis when the NIH group broke up. Gene Brownwell went to San Diego, etc. And Dean was my mentor for 10 years at UC Davis. I would say in terms of medical societies, Charlie Fish, who was for many years the chief at Indiana University, became a close friend and helped me a lot, helped steer me through the societal politics, if you will. And then when I became editor of Jack, I was blessed with having Gene Brownwald as the head of the publications committee. And I should have paid to have the opportunity to go meet with him for all the sage advice that he gave me. I would say those are three of a number of people who've impacted my career.
A lot of young people here at SCAI, if you had to give them a little advice looking over all this career, what would you tell them?
I'd tell them to go where their heart is. You know, fellows often say, or even residents, medical residents question, well, should I go into cardiology? I hear there are too many cardiologists. Or should I do intervention? Or, you know, I understand that the indications for intervention are going away and things like that. And I've always told them to go where their heart is. There's always room for a good doctor, always room for a good doctor. And they'll be much happier, and they will make whatever discipline they go in better. The other thing I always advise them, and I think is overlooked often, is to make sure that they take care of their non-medical life. You know, that's so important. If your family life is good, then everything else will follow. Conversely, if it's not good, then things are messy. And you know, we get wrapped up, medicine is a jealous mistress.
Yes.
And you get wrapped up so much, and especially for those of us in medicine, it's when we go home at night, our job's not done. That's
right.
When we're, you know, going over data and so on and so forth. There's always something to do. And so it's really important for these young people to carve out time for their non-medical life to make sure there's balance.
Sage words. Tony, thanks for coming by today. Thanks for joining us here.
Sure thing.
Congratulations, big fan of yours. And thanks to all of you for joining us here live from SCAI 2018.